All right, everybody, welcome back. Wednesday, final lecture of unit number 3, which is our pulmonary physiology unit. So this will be the last lecture that's included on the exam. Once again, that exam is going to be posted next Tuesday. I will post a review next Monday. The quiz is already open. I know some people have already started taking that, and that will be open until next Monday night as well. So make sure you're getting that done. Once again, if you're having any difficulties due to problems at just keeping up with the lectures, anything like that, make sure to reach out to me. There are a number of different resources that we have available to us. Grading duration has been extended, so there are a lot of different kind of mechanisms we can use to make sure that everybody gets the content delivery that they need, the understanding of the content as well, so that they can move on and have no problem with future classes in our department or in other departments as well. So make sure you get in touch with me if you're having any trouble whatsoever. Don't think it's like not a big deal or something that I can't help with, because in a lot of cases there are adjustments we can make. Okay, so keep that in mind. So we'll do some we'll do a quick questions. Actually, not real quick because we had a lot of good questions. Then we'll do a quick review, is what I meant to say. We'll go on to some spirometry, talk about how that can help us determine what diseases are. And then we'll go through the Valsalva maneuver. This is a nice little picture we have of a gentleman portraying the Valsalva maneuver for anybody who's done a squat or any sort of heavy lifting. I'm sure you're familiar with that as well. And then we'll just talk about a little topic that I kind of left out when we first went over the oxyhemoglobin curve, but I saw it on the quiz and I wanted to make sure to review it real quick just so that everybody was aware of some adjustments to the oxyhemoglobin curve before we finish up this section. So, and it's not 2022, that should be 2020. We have not moved into the future that far. Sorry for the typo there. Okay. So let's move on. Question number 1. Are forced expiratory volume and forced vital capacity the same thing? Why do we perform a forced vital capacity measurement before underwater weighing? Well, let's go back to our last lecture real quick. Number 27. Here we go. Forced vital capacity, FVC, is right there. So forced vital capacity... I just did that. That's right. 28. Forced vital capacity equals total exhalation. Forced expiratory volume generally is going to have a number after it. Forced expiratory volume normally is going to have a 1. And this is what we're going to be talking about today. And that means the max exhale in 1 second. So, if you think about breathing out all the way, okay, that probably took me a little bit longer than a second. The volume of air that came out of my mouth in that first second, that is going to be my FEV1. The total amount that came out of my mouth is going to be the forced vital capacity, okay? The last question, why did we have to perform this before we did our underwater weighing? Well, that has to do with an algorithm. Remember, once again, if we go back to the last assignment, let's go back here. If we're thinking about residual lung volume, we have to take people's residual lung volume into account when we put you underwater. Because the larger that volume is when you're underwater, the more you're going to float. Well, there are some algorithms out there that allow us to calculate or estimate your residual lung volume by looking at your forced vital capacity. So the reason that you did a forced vital capacity before you did the underwater weighing is because we wanted to be able to estimate your residual lung volume. Really, really cool question. Okay, let's move on. Number 2, an athlete may be breathing hard enough that they reach 5 liters of total lung volume. Okay, so when they're breathing, they are moving, their minute ventilation per breath is going to be about 5 liters. Does that mean they would take such a deep inhale to reach that volume? Or does that mean, let's cross this out real quick, they would have to fully exhale and then fully inhale to reach total lung capacity? Meaning that while you're running along really hard, you're like, okay, I got to breathe out all the way out. our breathing does not look like that when we are running hard. Okay, the last part of this, if with increased exertion comes increased breathing frequency, wouldn't this be uncommon? Well, the answer to this one is it's a little bit of both. You don't recognize it when you are breathing really hard, but you're actually breathing really deep as well. Remember, those increases in tidal volume happen at the beginning stages of exercise. So as we need some more pulmonary ventilation, right there, okay, the first thing that happens is that tidal volume goes up. Then when your breathing frequency goes up, that doesn't mean that your tidal volume goes back down. No, your tidal volume continues to go up incrementally a little bit as you get towards maximal exertion. So even though you're breathing faster, you're still breathing just as deep. Okay? So that's really important to remember as we are getting towards our maximal exertion. That breathing frequency increase plays a larger role. However, our tidal volume is still big. So the answer to this question is both. We do a little bit of both. We don't focus on breathing out as much as we can. It just happens because we're breathing in so much, we are forcing that out, and it comes out really quick. Okay. What kind of things can be detected from forced vital capacity? Well, I'm glad you asked, whoever wrote in this question, because that's exactly what we're going to be covering today. The two big classifications are obstructive and restrictive lung disease. Okay? And obstructive is trouble breathing out. You have a hard time breathing the air out. That would, think about, obstruction of breathing. If you had to breathe through a straw, it would be very hard to breathe out. Okay? Restrictive is hard time breathing in. So a classical example of restrictive would be somebody with cerebral palsy, who has trouble and they have a lot of mucus in their lungs. That's going to restrict their ability to breathe in. Muscular dystrophy is another example of this, of restrictive lung disease. Sarcoidosis is another kind of peripheral one that we see there with that. So we're going to be able to determine how we can use forced vital capacity, and especially the relationship of forced vital capacity with forced expiratory volume, to determine, is a disease obstructive? If a person has a low oxygen saturation, we can then do the spirometry, look at these ratios and determine, okay, is it obstructive or is it restrictive? Okay, let's move on. I'm wondering about people that deep sea dive. Sorry, I just cut and pasted real quick, without oxygen. Have they trained so much that they are able to do a lot of work before reaching a lactate threshold increase, or is it mental training to have the body not panic when it needs oxygen to compensate for the amount of lactate buildup? Because last lecture, remember, we talked about how breathing is related to lactate buildup. As we build up lactate, we change our blood's pH. As we change our blood's pH, that stimulus to breathe changes. We saw how that happens, okay? And that was over the course of exercise intensity. So the thing to remember about a person who's doing deep sea diving, they are going to be not exercising at a very high intensity, all right? So as they're swimming down, they have that big giant fin that they use. They are not doing that as hard as they possibly can to move down as quickly as they possibly can get down, okay? They are going at a very low intensity. And the reason that they deep sea dive at a relatively low intensity is because they don't want to create a lot of lactate. What they want to do is create a lot of energy aerobically, using the aerobic system so you don't produce a lot of lactate. All right? If you're doing that, even if you're not breathing in, the time until you reach that lactate kick is going to extend. So that's part one of it. Do they do a lot of work before reaching a lactate threshold increase? Well, they're just exercising at a capacity that doesn't produce a lot of lactate. But the second part of this question is also correct. Is there mental training involved that allows them to not panic? Absolutely. I'm sure if you ask any deep sea, kind of competitive diver, which I am not a fan of, by the way, because there have been deaths associated with it. But I'm sure if you ask any of these competitive divers, have you blacked out underwater? All of them are going to say yes. So what happens with them is over time they start to understand the difference between I have this sense that I need to breathe. I'm used to this. I know this is nowhere close to what where I'm going to black out versus the okay, I have felt this before. This is the blackout kind of feeling that I get. So they have a little bit better ability. You and I, who don't necessarily do this too frequently, we get one message, you need to breathe right now, and it's a good thing that we take people up on that. So the answer to this is both. Yes, they do some work to prevent that lactate buildup, but also they do some psychological training as well. All right, moving on. How is ventilatory threshold affected in people who have respiratory diseases like COPD and asthma? Or even damage from smoking? Look at this. Great question. Could you explain what is meant by the term collapsed lung and how this relates to different areas of breathing we talked about at the end of class? Okay, two separate questions right there. I may have put these together. Let's handle the first one first. How is ventilatory threshold affected in people who have respiratory diseases like COPD? COPD stands for chronic obstructive pulmonary disorder. What happens with people with COPD, asthma, and damage from smoking is you have an inability to get that air out of your alveoli into the atmosphere. What happens then is you're not able to raise the partial pressure of oxygen when you breathe in, and you're also not able to lower the partial pressure of carbon dioxide. What this ends up resulting in is a lack of oxygen into your blood, because remember that partial pressure of oxygen in the alveoli is lower, okay? And lack of ability to extract carbon dioxide out of the blood, because remember that partial pressure of carbon dioxide in the alveoli is higher than it normally would be because we have this obstruction. And we're going to be talking exactly about these when we go on to our FEV1 versus FVC graphs a little bit later, okay? Could you explain what is meant by the term collapsed lung and how this relates to different areas of breathing we talked about? Okay, so this is going to be restrictive. This is trouble breathing in. If your lung is collapsed, remember, our lungs, if you look at them from a macro level from far out, they have this nice kind of look that, look like this, look like that. But if you were to zoom in on these, remember, these are tiny little bubbles that are your alveoli. Each one of those alveoli has air inside of it. If we're talking about what do we mean by a collapsed lung, that means that all of those alveoli are going to be squished up against each other. Okay? If you think about bubble wrap, is you've popped all the bubble wraps and they're just like this. So what happens then is you have a fluid within your lungs that is a great lubricant, okay? And this lubricant is called surfactant. And that helps when you breathe in. You don't feel the friction of your lungs changing size because of that surfactant. However, when your alveoli collapse, that surfactant is between one side of the alveoli and the other. Well, you guys have all done this experiment before. You've had two panes of glass and you put a little bit of water between them and you stick them together like this. It is hard. There's suction created by that water. If you just took those panes of glass by themselves and smacked them together, you'd have no problem taking them apart. But with that water there, it creates suction, surface tension between those two pieces of glass. Well, that's exactly what happens in a collapsed lung. All of your alveoli deflate. There's surface tension created between the sides of all of the alveoli. So then if you try to breathe in again, you cannot inflate those alveoli because there's that resistance provided by the suction in there. So having a collapsed lung is a very dangerous situation. Generally, it's going to be one side or the other, and it's due to like a pneumothorax, like you get a chest wound that goes into your lung, and that kind of deflates the pressure differences, okay? And that's going to be a collapsed lung. We don't like that because of the pressure differential, that even when we can breathe normally, we can't fill our alveoli. If you can't fill your alveoli, you can't transport gas into your blood, and you can't transport gas out of your blood. Really bad. Okay, moving on. What would happen to the pulmonary capacity if someone who is an athlete chose to smoke? Anything really, meaning tobacco, cannabis, other types of things that you could take in. Back when I was in high school, the cool thing to smoke was cloves. Luckily, that's kind of gone by the wayside because I remember friends, coughing pretty hard when smoking their clove cigarettes. Anyways, what would happen to the pulmonary capacity? This gets involved with our obstructive relationship. A person who smokes regularly, they have symptoms similar to a person who has asthma. So a person who would smoke regularly to induce some of that damage to their lungs is going to have trouble breathing out. If you have trouble breathing out, that's going to reduce the ability of you to get oxygen into your blood. Now, is this something, if you have one cigarette, this is going to happen immediately? Not necessarily. But over time, I'm sure everyone has known somebody who's been a lifelong smoker. When they go up that flight of stairs, guess what they're doing? They have their hands on their knees because they're having trouble breathing out. If you have trouble breathing out, it's going to take you longer to breathe back in. Then overall, your ability to breathe and transport oxygen is going to be, reduced. So we don't want that. Okay, 2 more great questions from last time. Though there are no benefits to wearing elevation masks. Oh, somebody knew about my hatred for the elevation training mask. These are the things that people wear over their mouth like this. You see them in the gym. Generally, they're wearing like an Affliction t-shirt along with it. Something like that. They're probably doing the battle ropes while they're wearing this elevation training mask because they think it's going to give them, just crazy gains, bro. But we know elevation training masks, all that does is it makes it harder to breathe. The question here is, okay, elevation training masks don't improve your ability to transport oxygen because they don't change the partial pressure of oxygen. You're not going to get a stimulus for red blood cell production due to training masks because they don't stimulate the EPO by reducing partial pressure of oxygen. Okay, however, they make your inspiratory muscles work harder. So could this potentially improve your performance or have a training benefit due to the training that your respiratory muscles are getting? And the answer to this is yes. The military has done some work on this, and they've actually found that you increase breathing efficiency. And what this means overall is the amount of ATP needed to breathe when you're exercising goes down. Basically what it does is it's like weightlifting for your respiratory muscles. Think about it. If I can bench press 100 pounds, if somebody puts 90 pounds on that bar, that's a pretty hard effort. That's going to require a lot of my ATP to be able to do that because that's near my max. However, if my max bench press is 200 pounds and somebody puts 90 pounds on that bar, that's going to be super easy. The amount of ATP required for me to do that relative to my maximal amount goes down. And that's the same thing that happens with these these respiratory training devices. Okay. However, they have to be used correctly, not how people generally use them. Going on their bike to use them. They have to be used during some higher intensity exercise for longer duration, so you actually get that benefit. Okay. Last one. Similar to taking a deep breath before holding your breath underwater, when Apolo Ohno, or any athlete for that matter, yawned before their event, were they subconsciously increasing their O2 capacity for exercise, or was this simply a physiological way of staying calm before the event? The answer to this one is we don't really know. There's a couple reasons that people have been associating yawning with exercise. You might see this with some powerlifters sometimes as well. Even though they're not doing an aerobic sport, they're doing something like yawning or opening their mouth really big before they exercise. One thing that I saw in the literature is decrease brain temperature. Yawning, actually, the act of breathing in that air, because it's so close to your brain, can actually decrease the temperature specifically, and yawning is signaled within your hypothalamus, which is pretty darn close to the real back of your throat there. So if you breathe in a lot of cooler air quickly, that can actually bring down the temperature of your hypothalamus. So if you think about this as kind of a feed-forward mechanism, if you're about to start exercising and then you breathe really deeply and it brings down your temperature, your body says, okay, I know I'm about to get hot, but I just did one little thing to make myself a little bit cooler before I started. 2, the other thing that I've seen out there for the reason that people might do this, it has to do with that collapsed lung theory. Basically, if you breathe in very deeply, did my big yawn there before I ran my race, you're expanding your lungs pretty much as far as you can, all right? And when you do that, you're stretching your lungs and you're getting them ready for what they're about to undergo, okay? So it's a little bit of a preparation for your lungs. The last reason that people do this is reflex. We know that yawning in general is kind of partially involuntary. You have a little ability to control it, but not total ability. We've all been in the situation where we've seen a person yawn and then we immediately yawn. There's part of that that's just a reflex. So some people are more prone to this type of reflex before they exercise than others. The reason people might have this reflex is due to these 2 reasons right here. So, subconscious, absolutely. Are you going to increase your oxygen capacity during exercise? Probably not. There's just some small little physiological reasons that this might be taking place. Okay, let's move on to our review now. Really good, great questions, guys. Keep those coming. Okay, first one. Why does an increase of lactic acid cause the relationship between oxygen consumption and ventilation to change from linear? Which of those 2 increases disproportionately? Okay, so remember, we have our figure right here. As we are going along, okay, there's our oxygen consumption and ventilation, okay? Here's our O2 consumption. Here's our ventilation. And then at certain points we get a break, and then we get another break right there. And the reason this happens is because lactic acid, once in the blood and combined with sodium bicarbonate right there, is going to yield CO2. With that CO2, that's going to increase breathing stimulus. So the reason that lactic acid consumption changes our relationship between oxygen consumption and ventilation is because there's extra amounts of carbon dioxide that disproportionately increase our need for ventilation, okay, outside of our need for oxygen consumption. Okay, what is the purpose of all the branches within the conducting zone, right? Remember, we had that figure towards the end of Monday's lecture that showed the bronchi, and then that, and then we get another division right there that looks like that, and then this divides even more. These sides divide, and we're going further on. Okay, so we get these further divisions within the pulmonary tree is what they call it. What is the purpose of those? The purpose is to create surface area. Think of this as like the opposite of the game where you take a piece of paper and try and fold it 7 times in half. Every time you fold that piece of paper, you're exponentially increasing the number of sheets you have to fold in half. So even if you can bench press 900 pounds, folding that last one in half is pretty darn hard because you're trying to fold in half thousands of sheets of paper. Okay? The opposite happens as we are dividing going down the pulmonary tree. Each branch has an exponential increase in the amount of surface area that's created. As we create more surface area, we enable ourselves to transport more gas. Okay, last one, little fill in the blank here. Forced vital capacity is a combination of which factors that we discussed? Well, it's going to be part inspiratory reserve, Remember, that's at the top of the curve right there. Okay? It's also going to be tidal volume. Just our normal breathing. And last, it's going to be expiratory reserve as well. Fantastic. So understand how each one of those different definitions plays into each other. Which ones equal when we add them together other ones. Okay? Understand how to do that for the exam next week. Now, let's move on. New information. Aha. Here we go. Getting on to our FEV and FVC. Let's do our definitions first. Right here at the bottom. Forced expiratory volume versus forced vital capacity. Okay. Our forced expiratory volume. This is going to be the volume of air maximally exhaled in 1 second. And generally we will call that FEV with that little subscript of a 1 right there. Now, if we want to talk about forced vital capacity, right here, this is the volume of air, the total volume of air maximally exhaled. Without that 1 second kind of limit on it. It's the total amount of air that you can breathe out after taking a maximal inhalation. All that air that just came out is my forced vital capacity. The forced expiratory volume is that first second. Okay, so let's see how these normally look if we were to graph these. Now, we've done our maximal inhalation and we know our normal amount of air that we have in our lungs after a max inhalation. Okay, this is normal. Let's do this right here. Normal. And let's zoom in. Just so we can do this and see this a little bit more clearly. All right, here's our time 0 right here. So we know at time 0, we're going to have about 6 liters of air in our lungs. And as we decrease, when you breathe out, that first little bit of breathing out, you have a lot of flow. You're getting rid of a lot of air real quick, okay? So this comes down real quick. And let's just draw this line up. Actually, we'll do this. Okay. And this is what it looks like. And you might see even a little bit of a rebound here at the end. You know, when you breathe out all the way, you get that little bit of an inhale at the end. So that's generally what this is going to look like on our figure. Okay, so if we wanted to look at our FEV versus FVC ratio, how would we do that? Well, the first thing we would do is calculate our FEV1. And that is just this to this. Because here's our 1 second right here. So what is the volume that is expired in that first second? Well, we started at 6, and then we were at 2 by 1 second, so that's 4 liters. That's our FEV1. Well, if we wanted to look at our FVC, we would take this, we start the same. Remember, that's the total volume that's expired, okay? And we go down to 1. So we start at 6, we go down to 1, so that's a total of 5 liters. 5 liters equals FVC. Now, if we do the ratio of those, FEV1 over FVC, that's going to equal our 4 liters over 5 liters. That ratio is 0.8, or 80%. In a normal person, you are able to exhale right around 80% of your total forced vital capacity within that first second. That shows good lung function. Here's our first second, right there. We got 4 liters out in that first second, 5 liters out total. The ratio there was about 0.8. Now, what happens to this figure if we have somebody with obstructive lung disease? All right? And remember what we said about obstructive lung disease. It's generally trouble breathing out. Let's move on. And it's interesting, people with obstructive lung disease with COPD, you might even see that they have like an expanded chest. Their total lung capacity may even increase because they're trying to compensate for their inability to breathe out. So they actually breathe in more air just to compensate for the fact that they can't breathe out. Okay, so let's think about this here. We're going to have them start, same thing, right at 6 liters. We're not going to say that their total lung volume has gone up at all right? But what we're going to do is we're going to show that in the first second right here, let's do this right here. Okay, nice vertical line. We'll make this a little bit thicker. Right like that. And something that looks like that. All right? So we're seeing right here, they are not breathing out to this 1 liter. They're only breathing out to about 3 liters. They have 3 liters left in their lungs because there's an obstruction to getting that air out. Remember, we talked about the inability to exchange that air in the alveoli. All right? So let's see what happens if we let's just look at these two figures side by side real quick. Look at the slopes in that first second. Whoa. The slope in the obstructive person is way shallower than the person who's normal, okay? So let's do the math here and figure out what the difference is. If we look at this first second, we're here to about here. And I'm going to say that's about 1.3 liters equals our FEV1. But if we look at the total amount right here, we can see, okay, well, they went a little bit below that 3. So their total volume, their FVC, equals about 3.1 liters. So they get 3.1 liters out. Well, now if we do our ratio once again, 1.3 over 3.1 liters, that's going to give us a ratio of about 0.42. Okay? Yep, that looks about right. 0.42, so only 42% of their total FVC was exhaled in that first second. Generally, what we're going to do is we are going to diagnose obstructive with FEV1 over FVC, which has to be less than 0.60. So if you're a pulmonary physiologist or a pulmonary rehab and you do some spirometry with one of your patients and you notice that their FEV over FVC ratio is less than 0.6, you can pretty classically say, okay, I think this person has some form of obstructive lung disease. Now, let's move on to our last kind. Restrictive. And once again, this is something similar to like sarcoidosis, okay? A little bit less common than our obstructive lung disease. And remember, with restrictive, that's trouble breathing in. So in this version, we're going to start this person a little bit lower. They're actually going to start at only 4 liters. Their total lung volume is only going to be 4 liters, all right? Once again, we'll draw our line at 1. Nice vertical right there. And what do we see with somebody with restrictive lung disease? Okay, well, they're going to go down to 1 as well. Just like that. 1, 2, yep, that looks good. And if we looked at their FEV1 equals about 2.8 liters here. Okay, 1 liter, 2 liters, 0.8. Good. But if we look at their FVC, once again, right around 1, 2, 3, and a little bit. 3.1 liters. And that 2.8 over 3.1 equals 0.9. So we are higher than we are with our normal person who's right around 0.8. It's a little bit more challenging to diagnose a person with restrictive lung disease. Generally, it's going to be a person who has trouble breathing who doesn't have obstructive. But you can also look at this, and there's a little bit of a diagnosis, which we would say that FEV1 over FVC is equal to or above normal. But generally, one thing that you're going to see is that FEV1 volume, this 2.8 liters, is less than 75th percentile. For age. So we would need one more piece of information in order to diagnose this in a person. We'd need a table that shows for every age and sex as well, how much is the normal FEV1 for that person. Over here in our normal person, we showed an FEV1 of 4 liters. In our person with restrictive, we showed 2.8 liters. Would you think that's less than the 75th percentile? Absolutely. So even though their ratio was okay at 0.9, even above what we saw in a healthy person, we would initially think, okay, if you just saw that number, oh, this person looks good. But if we looked a little bit deeper and looked at the FEV1 and saw, hey, that's pretty low, a total volume for FEV1, let's check to see if this person might have some sort of restrictive lung disease. Okay? So that's how you can use the spirometry to determine a person's disease state. Let's move on really quick. We're going to pass by one of my favorite research articles of all time. And the reason that this is one of my favorite research articles is because it talks about the Valsalva maneuver. And if you've ever been a personal trainer or been somebody who's lifted weights, you have heard a lot of different kind of conjecture about what is good to do when you're lifting something heavy. Okay? If you're going to do a heavy squat, what do you want to do? Well, if you're a personal trainer, you've probably been taught, hey, you want to make sure you breathe out during the contraction. So you, on the way down and on the way up, you're breathing out as you stand up out of that squat. But maybe if you're a power lifter, you've heard, oh, you want to hold your breath while you're pressing because that's going to increase your blood pressure and that's going to increase the amount of oxygen to your legs, and you might be able to lift a little bit heavier if you do that. It's a natural reaction, okay? So this group right here, Hagens, Petrick, Sheikhzadeh, and Norden did a really cool study where they actually, if we look at this picture, they were able to measure, first of all, the amount of force a person exerted. So this wasn't a squat. What they had the person do is kind of bend down to about 30 degrees in the knees where they were able to create the most force. If you think about that, if you're doing a quarter squat, you can lift a lot more than if you're doing a full squat. So we know right when those knees are about 30 degrees there, we can produce a heck of a lot of force, okay? So we wanted these people in a good position. Then had them reach down and grab a little handle right here and push with their feet and pull as hard as they possibly could. While they were doing this, they measured 3 things. First, they measured the amount of force that they exerted on that handle right here. Second, and that handle didn't move. They were just pulling on an immovable object, and there was a strain gauge that was able to measure how much force they were producing. Next, they measured the airflow. They had one of those same mouthpieces that you guys have used in lab in their mouth while they were doing each of these 3 exercises. Okay? But inside of that mouthpiece, they had a wire. And this wire went in to their abdomen. Okay? And they could measure their IAP, interabdominal pressure. Aha. So they measure the force, airflow, and IAP. Well, let's see what happens if they did this in 3 conditions. 1, breathe in and before you do the contraction, and then hold your breath. Another, breathe out, I believe. Yep, breathe out right before the contraction and hold your breath out and then do the pull. And the last one was breathe in and then breathe out as you're doing the contraction. Okay? Inhalation hold, exhalation hold, and inhalation and exhalation. If we look at force across these 3, they were exactly the same. The person was not able to exert more force by holding their breath, which is what we classically would think about those powerlifters holding their breath and their nose starts bleeding or something like that. There's no benefit with these untrained people for that. But if you look at the airflow, look at that. The airflow was, or the interabdominal pressure was very high. So in that interabdominal pressure, when you're holding your breath like that, after you breathe in, you can create a lot of pressure in your abdomen. If you exhale and hold, and if you inhale and exhale, that pressure in your abdomen is way lower. Okay? So, what are the take-homes of this? Overall, doing the Valsalva maneuver, holding your breath and pressing against a closed glottis while you are doing these types of heavy lifting is not going to make you produce more force. All it's going to do is create more pressure in your thorax. The one benefit of that might be when you are doing heavy lifts like a squat, if you increase that pressure in your thorax, it might prevent you from falling forward. Because you have more pressure, you can be a little bit more rigid in your thorax and hopefully stay up straight a little bit longer. Okay, let's finish the lecture. Last thing, oxyhemoglobin curve. Really, really important part of our overall section that we talked about. We talked about how to use this to calculate a VO2 difference, but we didn't talk about a couple modifiers that can create a left shift or a right shift in this curve. And overall, if we think about this right shift right here, this tells us about a reduced affinity of our oxygen for our hemoglobin. So what happens is, and if we were to carry these lines out, let me do this right here, right like that, right like that, okay? This reduced affinity doesn't happen at R100. The importance of that is to say, okay, so when you are trying to saturate your hemoglobin with oxygen molecules, there's going to be no difference. You're still going to get that 98 to 100% saturation in all of these cases. However, the difference is going to occur when we're at the muscle. And remember, let's say 40 is what we're talking about right here in this example. Okay? The classic partial pressure of oxygen at your muscles kind of at rest. Well, if a right shift has occurred, we have reduced our affinity at the muscles of oxygen for hemoglobin. And therefore, the amount saturated at this point right here is going to be about 62. So we've gone from 98%, let's draw this with blue, 98% down to 62. So 72, 82, 92 plus, we'll do 6 more. So we got 36% off load, right? Well, what happens if we're at the other side? if we're on the green side where we have had a left shift? Well, now we've gone from 98% down to 80%. This is our green shift right here. So we only have an 18% off load. So a right shift in the curve is going to result in more oxygen coming off of hemoglobin when it reaches the muscle. And that makes sense because all of the things that happen, actually let's just do this with our highlighter, all of the things that are happening right here happen with exercise. Does your temperature go up? Yes. Do you produce more 2,3-DPG, which is a substrate of glycolysis? Yes. Does your concentration of hydrogen ions go up? Yes. All three of those things happen when you're exercising, so it makes sense we're going to change this curve to get rid of more oxygen when it gets to the muscle. The other things happen generally when you're not exercising. You don't see a left shift quite as often as you will see a right shift, but these are the opposite. Decreased temperature if you're really, really cold, decreased 2,3-DPG, and decreased hydrogen ion, and also increased carbon dioxide, I believe. So the main things overall we want to focus on here is the right shift, and the reason we have that right shift is because we have a decreased affinity for oxygen on hemoglobin, and that's going to result in more offloading of oxygen and hopefully a greater amount of exercise capacity. And this really comes into play as we get further down the line here. If you look, for example, at 20, we have a big difference of almost 15 percentage points when we draw those horizontals across. And a difference of 15 percentage points could mean the difference between being able to continue exercising and not. Okay, send in those questions. I will answer those questions along with the general exam review next Monday. There is no lecture on Friday. Get those quiz number 3s going and get that study guide going. And I'll see you guys next Monday.